You have said that data completeness criteria applies to numerators, and that Medicare wants us to report 100% of our denominators, and that the gold standard for denominator data is claims data. But there are many measures that have clinical data that define the denominator. Can you explain this?
Thanks, Gene. I was hoping to get that question. It is a source of some confusion. In the early days of quality reporting, measure authors limited denominator specifications to claims accessible data. That proved limiting and swelled the denominators for many measures to massive levels. Now we see a mix. At Mingle, we take a stepwise approach to calculating denominators. Every time we import claims data, we run the data set against claims accessible denominator specifications, producing what we call denominator candidates. Your true denominator patients will be in that group, but it swells it to include patients that for which will be excluded by clinical factors that we don't yet have. We can't get that final denominator count until the clinical data is added in. But when you're calculating reporting rates and answering the question, am I meeting data completeness requirements, we find that calculating from the denominator candidates yields a credible calculation. If you examine the logic, true eligible instances can never be higher than the denominator candidates. All true eligible instances are contained within the denominator candidates. The factors that make them different numbers are reasonably expected to be similar in occurrence rate from practice to practice. And despite not being able to find the actual final denominator count, counts of denominator candidates reflect the actual distribution of eligible instances across your many practices. And it's a source of credible calculation of data completeness. The percentage in your denominator candidates should be very close to the percentage in your true denominator counts.